Hello. Can you hear me?
Yes, sir.
Okay. Yeah. Okay. I just need 1 more minute. I just get my slides open. Please wait. Just give me a minute. Can you hear me? Hello.
Yes, sir. Yes, sir.
Yeah. Just give me a couple of minutes. I'm just getting my slides open.
Okay, sir.
Hello, sir.
Yes. Who's that?
Sir, good afternoon, sir.
Yeah. Who's that?
Sir,
Good
Nikhil.
afternoon. Yeah, Nikhil. Tell me.
Nothing, sir. I was trying to call you, sir. I thought it will be late today.
No. I just 2 minutes late. I'm just getting my slides open.
Oh, okay, sir. Yes.
Right. How many people have joined? About 50 people. Okay, good. Time to go start. I'll just share my screen. Meanwhile, you can identify a few people to answer, 2-3 people.
Yes, sir. Yes.
Okay. Can you see my slide?
Yeah, sir.
Okay. Right. So, who is going to answer questions today?
Yes, sir. Ganesh Ingle, sir, you're there? Saurabh Kapadia? Abhijit Khadtare?
I'm not hearing any response from them. They are there?
Yes, they are there in the meeting.
Okay.
Wasim, Dr. Wasim, you are there? Rupesh Srivastava?
Yes, sir.
So Rupesh is yes, is it?
Yes, sir. Yes.
Okay.
Yes, sir. Yes, sir. Good afternoon, sir. Yes.
Who else?
Patel Kashyap? Kashyap, you are there?
Yes, Nikhil.
Yeah, Kashyap. Okay.
Okay, sir. One or two, sir, more I'll just take.
Okay. So I'll start. You can identify meanwhile.
Yes.
Right. Good afternoon, everybody. So today's talk is basically because I think one of you requested me to take a talk on surface markings of the cardiac chambers so that you are able to identify the angiograms, because you people are used to coronary angio, but you're not used to chamber angiograms, and you do not know the radiological anatomy of the heart. I have prepared this talk. It might take a little longer than on usual time. Do you have any class after this?
No, sir.
No, sir.
Okay, so I'll try to finish it by 3:30 or so. Okay, so if you remember, I told you that we'll discuss one day the anatomy of the heart as seen in angiogram and how to identify it. And there are some ways of learning it. Some of you who are familiar with angiogram, maybe the senior guys, may be already familiar with what I'm talking. But a lot of you may not know what the views are, how to identify chambers. And moreover, even the ones who know, it's always good to revise the angiographic anatomy, because this is one of the most crucial things in your cardiology practice. Whether you do echocardiogram, whether you do heart surgery, whether you do diagnostic angiography of congenital heart disease, or you do coronary angiography, or you do coronary intervention, or you're going to do TAVR and pulmonary valve and other implantation mitral valve repair, the radiographic anatomy is the single most important thing. Now, this is something which it must be burnt into your hard disk. We don't think twice before we say 1 + 1 is equal to 2. We never think twice. No, it's ingrained in your brain. 2 + 2 is equal to 4. Nobody thinks the answer. We already know it. Answer that is the way the radiographic anatomy should be in your mind. Okay, that's the whole idea of this talk. Some of this is very basic. Some of this will be things which we haven't discussed before. So the heart is a very complex structure, as you know that, and it's a very nicely, neatly, very compactly packed inside the thorax. So that's okay for its protection and for its efficient function. But when we want to image it and identify chambers and different parts of the heart, it makes our life very difficult. You can see that it's not a simple geometrical structure. It's neither square nor round nor spherical nor oval. It doesn't. It has its own shape. It has a very complex contour, and it's lying in a very oblique position in the heart, in the chest, surrounded by many other structures. And there are many structures attached to it, entering it, leaving it. So each one of these is important for our cardiology diagnosis. Now, if you remember, I told you that I use a heart model to understand the anatomy of the heart. Now, this is a model I was talking about. This is, I don't know what, made up of some light material, plastic or something. It is colored blue and right. It's just about the size of my hand. So that's about the size of an adult person's heart. It's a normal expected size of a heart. And there are different models. You will have hard model, you will have soft model, you will have intricate models. This is a very simple model where the exterior anatomy is as of a normal heart, and you can actually take out the anterior wall away from the model and see the interior of the heart. And as you can see, the heart is a very, very complex structure. It doesn't, although we draw diagrams like RA on top of RV, LA on top of LV, and RA and LA side by side. It's not like that. It's a very, very complex anatomy, and that whole set of chambers are twisted around each other. And this is the anterior wall where on the epicardium where all the coronary arteries and all running. So we'll be using this model. I use this model very, very often to understand the anatomy. I use it now and then, even now to when I report an angio, and I always have it on my table so that when I talk to a patient, I can explain the anatomy to that patient. Sometimes when I have doubt about an angiogram, I have to go back to this model. So I strongly recommend that you people should get my. Now, the ideal thing would be to have a human heart in your hand, but that's not possible. Pathological specimens are very, very difficult to get, and therefore this model is the next best. Okay. All right. Now, Radiography started in simple, anteroposterior views, and that's the model I was talking about, with the anterior wall put onto it looks like it. And if you look at the plain chest X-ray, it's very easy to identify it's a plain chest X-ray when you have all the bones visible and the clavicles visible, the spine. Straight away you can say it's a frontal X-ray. You also know the posterior anterior based on because the scapular nerves are on that, because you're seeing the entire set of two ribs, entire set of clavicle, and therefore you know everything is symmetrically placed around the midline, and therefore it must be a frontal X-ray, that is anteroposterior or posterior anterior view X-ray. And the heart inside the chest is sitting in this more or less this position, and that just correspond to that. So if you have an anatomical model in your hand, you can identify what are the cardiac borders. The uppermost border is formed by the superior vena cava here. The ascending aorta lies just inside the superior vena cava in normal heart, and therefore it may not reach the cardiac border. But when the ascending aorta dilates, it forms a convex border here again. And below the superior vena cava, you have the right atrium. Right atrium goes all the way to the diaphragm. In fact, you don't see the IVC at any part, and therefore the RA goes all the way to the diaphragm. That's about the right cardiac border. When you come to the left cardiac border, this one is actually in the just below the suprastral notch. It's under the clavicle, so you won't see it in the frontal chest X-ray. So the first structure you see below the clavicle is the aortic knuckle. So you see that corresponds to the shadow here. And in fact, I have described all this here also. Can you see? You can correlate the X-ray, the model, and the line diagram here. Are you able to see this figure well?
Yes, sir.
Yes, sir.
Okay. Now, so just below the aorta, you get the bump of the main pulmonary artery here. The LP actually goes posteriorly, arches backwards and arches down. Although I have shown it here, you don't really see it in the model because it's going backwards and around. And once the branch is going to the lung, you don't really clearly see it. Just below that, you see a little bit of the LA appendage, and that's the LA appendage here. And then you see the left ventricle. Now you can see that the right atrium forms the cardiac border here, the left ventricle forms the border here, and the right ventricle doesn't appear anywhere in the cardiac border. It lies in the middle here. It lies between the interventricular groove, that is the left anterior descending artery here, and the AV groove here, that is the right coronary artery, and the diaphragmatic border. So that's what is shown here. The right ventricle is lying, doesn't form the cardiac. Therefore, in a frontal X-ray, you never talk of right ventricular enlargement. Okay, it never forms the cardiac border. And of course, the right ventricle leads to the pulmonary artery, which is well shown here. So now you can correlate a simple straight chest X-ray with the cardiac structures, and you also know where the expected chambers are. I showed you a pacing lead last time, which was perforated, if you remember correctly, and the lead was almost till here. You remember that X-ray? Any of you?
Yes, sir.
Yes, sir.
Yes. So, if you know that the normal right ventricle stops quite some distance from the left cardiac border, so if you have a chest X-ray today and a chest X-ray tomorrow, and the lead has migrated to the left cardiac border, you would know that it is in the left ventricle. So that's the importance of knowing the surface anatomy, and this is a simple, straightforward frontal view. But obviously, with such a complex structure like now in the frontal view, remember what you're seeing is actually only the right atrium and the right ventricle. The entire left heart is a little bit is seen here, but the entire left-sided structure is actually lying behind the right-sided chamber. You're not seeing it. Now, although we call it right atrium and left atrium, the left atrium is actually behind the right atrium, behind this here, and the left ventricle is predominantly behind the right ventricle. And what you're seeing when you remove this wall is actually the ventricular septum. You don't, okay. So if you remove this right ventricular wall, you'll see the ventricular septum. And therefore, that's what I've shown in the next figure here. For example, in the frontal view, you see this. There's a taken picture. Therefore, don't mind this labeling. But you can see that the right ventricle actually superimposes the left ventricle completely, and only a little bit is seen on the side. Therefore, when you do an RV angiogram, you see the right ventricle, but you will still see a little bit of cardiac stellate outside the border of the right ventricle, the left ventricle. When the dye goes to the recirculation, when the dye goes all the way from pulmonary artery, pulmonary vein, back to LA, and then it comes to LV, you will see the left ventricle filling, and that time you will see this stellate. Now you don't see the LV here because the LV is hidden behind the RV, and the contrast has to reach through the pulmonary vein to the LV to be visible. So in a frontal X-ray, you see this view. You should take away the RV, or if you do an RV angio and follow it through the levo phase, you will see the LV. Now, do you understand how the anatomy of the heart is when they are placed in the anatomical position? They are called left to right, but they are actually more anterior and posterior, right? Hey, you have to say yes or no.
Yes,
I don't.
yes,
Yes. Otherwise, I won't know whether you are hearing or not. Okay. So now that's a very simple frontal view. And remember, in radiology, we are seeing what is called a sectional anatomy. No, we are not seeing a three-dimensional anatomy, either in angiogram or in echo or in CT or in cine angiogram, MRI. We don't see a three-dimensional anatomy. We only see a two-dimensional. So when you see two-dimensional view of any structure, you can have two views. If somebody sees this cell phone in this view, he will say it looks like a pillar, doesn't it? If somebody sees it in this view, he will say it looks like a something flat instrument with some buttons. So if you remember the story of four blind men who described an elephant, no? One blind man caught hold of the leg, one blind man caught hold of the tail, one blind man caught hold of the ear, and each one described the elephant according to his own description. But the total description will come only when you get all these views together. Am I correct? So the message is that radiological anatomy always has to be sought in a minimum of two views, preferably in as many views as possible, to get the full picture. Otherwise, you will get a very distorted. You will think that the structure is a pole, or you will think that it's a flat structure. But it's neither. You know, you have to get a three-dimensional to get at least two orthogonal views. Orthogonal means two views that perpendicular to each other, or preferably as many views as possible. Okay. So then people started taking lateral chest X-rays. So what is the lateral chest X-ray? Now if you see when you turn the heart in your hand into your lateral view, look at it from the side, the contours look quite different. The heart has become much more rounded. It's no longer oval. It's rounded. The length, it looks much shorter in length because the apex is coming towards you. No, it's coming towards you, and it's sort of the front of the heart looks somewhat flattened out. In a chest X-ray, how do you identify lateral? Very easy, because the spine is at the back and the heart has cleared the spine. The heart is entirely in front of the spine. Okay, that you know that it's a lateral view. And anteriorly you see the sternum, and the sternum is well profiled. The final proof of being lateral, you see, that there are two sets of ribs. One is the right-sided ribs and the left-sided rib. Now both the ribs are perfectly overlapping each other. So you see only one set of ribs. So that is a lateral view. If it was oblique, you will see, some ribs in front of the spine and you will see some ribs behind the spine. If it was an oblique view. Okay? So that is how a lateral view goes. You should keep the heart in your hand always when you interpret an angiogram so that you're very clear about the lie of the heart. So, but then AP and lateral is not enough for interpreting cardiac structure, because again, it's such a complex structure, two views probably are not enough, and therefore you need oblique views. So started taking oblique chest X-rays. So when you take an oblique chest X-ray, you can have a right anterior oblique or a left anterior oblique, and that's fundamental to your interpretation. You must know how to identify left anterior oblique, how to identify right anterior oblique. Now, right anterior oblique is very easy. The typical contour of the heart, no? The contour of the heart is that egg-shaped or ovoid shape is there. in right anterior oblique it becomes exaggerated. It really forms very well, right? And the spine moves towards the left. That means if you do right anterior oblique, the spine moves towards the left of the heart. Well, left means the operator's left I'm talking, or patient's right. Okay, I shouldn't confuse. Okay, we'll talk about the patient's left and right now, right? So this is the patient's left and this is the patient's right. So when you do right anterior oblique, the spine moves towards the right and the heart moves towards the left. Now, important to differentiate that it is not lateral. When you do a RAO view, what happens is the left-sided ribs are seen in front of the spine, but the right-sided ribs are seen behind the spine. Right? So this is not lateral. One set of ribs are seen here, one set of ribs are seen here. Whereas in a two lateral, you should see only one set of ribs. Okay. Secondly, the heart is moving to the left and the spine is towards the right. Therefore, this must be right anterior oblique view. In contrast, when you go to the left anterior oblique view, as you rotate the patient to left anterior oblique view, the spine moves towards the left of the heart. And now you see the, I'm sorry, I made a mistake. In RAO view, you see the right-sided ribs in front and the left-sided ribs behind. Okay. In LAO view, you see the left-sided ribs behind and the right-sided ribs in front. Right? So this view should be imprinted in your patient. The ovoid shape, the position of the spine, and the set of two ribs. If you see this shape and this shape corresponds. So anterior and RAO look like similar to each other, and this shape of the heart, no, a rounded shape with a shortened apex corresponds to the LAO. These two look more similar. The lateral and LAO will look similar. RAO and AP will look similar. Now it's very easy to make out RAO and LAO.
Excuse
Yes?
me, sir.
Yes.
Ribs, which is posterior and which is anterior? Can you just repeat it, sir?
Yes. Okay. So can you imagine the chest? Let's go back to this. So when you rotate this patient, oh sorry, 1 second. See, this patient now rotates that the right shoulder comes forward and the left shoulder goes backwards. Can you, this frontal X-ray, imagine the right shoulder comes forward and the left shoulder goes backwards. Okay. And you're looking from here. Then the right ribs are in front of the heart or front of the spine and the left ribs are behind the spine. That is RAO view. Okay. Now imagine this
Yes, sir.
X-ray,
Yes.
you rotate this way,
Yes, sir.
that the left shoulder comes forward and the right shoulder goes backwards. Okay.
Yes, sir.
When the left shoulder comes forward and right shoulder goes backward, and you're looking from this side, from here, like this, then the left ribs will be in front and the right sided ribs will be behind.
Okay, sir. Okay, sir.
Okay.
Thank
No, you don't identify which ribs are behind and backward.
Yeah, yeah.
All those things you don't need to identify. I'm only saying that they don't overlap like this. That's all you need
Yes,
to
sir.
know.
Yes, sir.
Okay. You make sure that they are not overlapping with each other, and then look whether the heart is in front of the heart is to the right of the spine or left of the spine. That's all you need to make out. And you have to look at the shape of the heart. Is it rounded or is it oval? These are the 3 points. Okay. So this is LAO view and that's RAO view. Now you can also have surface markings in LAO view and RAO view, but I'll be using more of this in when I discuss the angiogram. But again, you must know what is the surface anatomy. When you do RAO view, if you do a steep RAO, the heart has come clean of the spine. It has left the spine and come clearly in front. If you do a little shallower degree of RAO, then some of this heart will overlap the spine. So that is how you know whether it is shallow RAO or steep RAO. Now, Because you don't have to when you are shown an angiogram and asked in the examination or in practice, you don't have to say whether 20 degrees RAO or 30 degrees RAO or 45 degrees RAO. That's not needed. All you have to say is mild RAO or steep RAO or lateral. Right? Now mild RAO means the cardiac fillet will overlap the spine. Steep RAO means it will clear the spine. Lateral means these two ribs will be overlapping with each other. Got it?
Yes, sir.
Yes, sir.
Yes, sir.
Now when you come to the cardiac anatomy, when you rotated the heart in RAO view, the right atrium still forms the border, but now it is the posterior border. No longer the right border now, because RAO view, this becomes the posterior border. Right? Now, because you have rotated the heart, the SVC doesn't form the cardiac border again. Now, the left atrium comes and forms the posterior cardiac border here. Left atrium and pulmonary veins form the border. Of course, you won't be able to see the pulmonary veins and all, but you will see a vague shadow here, a rounded shadow. Now, what forms the anterior border? Anterior border formed by the right ventricle and going into the pulmonary artery. Aorta is not seen inside the cardiac fillet, but the arch will be seen in the high up in the neck here. So these line diagrams are something very, very important. You must always have it in your memory. When you go to LAO view, now why is it LAO? Because the heart is somewhat rounded. It is the apex is foreshortened. The spine has gone to the left of the heart. It has gone towards the left of the heart, and it's oblique because the two ribs are not overlapping each other. Now, what is the posterior-most structure here? Left ventricle. It forms the posterior cardiac border, and just above that formed by the LA. LA is not seen in the frontal view, but in LAO view or lateral view, it will be seen forming the upper posterior cardiac border. Whereas when you come to the front, it will be the anterior border is formed by the right ventricle and going up into the pulmonary artery. Anyway, we will be discussing this more when we discuss angiogram. Okay, just remember these two figures. It will come again and again when you discuss angiograms. Right. Now, again, I have to come. Heart is a very complex structure. Now, if you are looking at the pulmonary artery, it starts here, but then it goes obliquely, then goes backward, and then it goes downward. The right pulmonary goes, the arch forms the right side, goes backward and to the left. So it's all a very complex structure. Coronary artery, if you see, the left coronary artery starts from the aorta, comes behind the pulmonary artery in a horizontal manner, and then it obliquely, and then it goes here, and at the apex it turns around and goes backwards. Now the complex course of the coronary artery is shown here. For example, this is the left coronary artery. Now you see the circumflex, how it comes. The first part is different from the second part, and then the third part is different. The last part is curves around. Similarly, RCA comes forward, right AV groove makes a loop around the AV sulcus, goes up, forms a loop, and then goes down. So such a complex structure you cannot see in one view or two views, or not even in AP, lateral, RAO, LAO. You probably need different angulations to see all parts of the heart and all parts of the coronary arteries. And that's the importance of taking multiple angiographic views and angled views. The view which shows the left main artery may not show the mid LAD. The view which shows mid LAD may not show the distal LAD. The view which shows proximal RCA may not show the distal RCA. You may need different views. Therefore, you need more than one view, multiple views, and that's why. And when you open the heart for ventricular angiogram, it becomes even more complicated. Look at the septum. The septum is normally when we draw a diagram to explain to anybody, we just draw a RV, LV, and then we all draw a straight line. This is the septum. But the actual septum is not a straight line. It's a very, very curved structure. It has curvature in two views. If you remember your echo in short axis, it forms a curve like this. It forms a curve, isn't it? Do you remember the curved septum in short axis view like this? Like this, it forms a curve. Sir. Okay. In addition, there is another curve. Can you see this? It comes up like this and it bends backward. this is another curve. So the septum is a very complex structure. It's curved in more than one plane in different places. Therefore, again, one view will not show the all parts of the septum. Similarly, RV also, all parts may not be shown in one view. Whatever view shows the right ventricular inflow may not show you the right ventricular outflow very well. You see, the right ventricle comes from behind, comes forward and to the left, and then it goes forward superiorly, and then it arches backwards into the RV outflow. So such a complex route will not be shown in one view. Again, left ventricle, can you see the septum is curved? So if you take a horizontal section, it is curved like this. And if you take a longitudinal section, it is curved like this. So if you have a VSD in this location, you will need a different projection to profile it than if a VSD is in this location. Okay? So therefore you need multiple views, and multiple views not only in AP lateral, RAO and LAO, but you also need cranial RAO, cranial LAO, caudal LAO, plain caudal RAO, and multiple views so that you can see all parts of these curved structures. That's the most important thing. And that's why you need a cath lab, the modern cath lab. The three major components to give you a diagnosis. Of course, the machine is very important. The subject, you have to do a procedure safely and get him out of it. And the third most important thing is you. And the most important person who does the interpretation. The first two factors will not give you the interpretation. You have to interpret it with the use of this piece of equipment. Now the modern cath labs, I think you're all familiar. Quickly going through it, you have an image intensifier here, and so X-ray source here, and an image intensifier here, and the patient lies on the table, and therefore this is the view for a anteroposterior or frontal view. You turn it around, and in modern machine you don't move the patient. When we learned cardiology, the tube was fixed and the patient had to be rotated, but now the machine rotates. So this is the lateral projection. I think this most of you are familiar, and I won't spend much time on it. You can also do LAO view, where the X-ray source enters from the left posterior aspect of the patient, and the image intensifier is in close proximity with the right anterior chest. That's the left anterior oblique. You can have different degrees of left anterior oblique. As I said, mild, moderate, and true lateral. And you can add cranial tilt when the X-ray tube goes caudal and the image intensifier goes cranial. You get what you call a cranial tilt. You can do cranial tilt with any degrees of obliquity. That is, you can do cranial tilt in RAO or LAO or in a plain AP view, or you could do the reverse in caudal view. Now, it's important to know how an angiogram looks in all these views, because you never know in a given patient what view will profile a particular part of the coronary artery or a particular part of the heart. So you have to know the cardiac anatomy in every single projection in space. In 360 degrees, if I can turn the heart in any direction, in any way, if I show you the heart, you must be able to identify on an angiogram what chambers lie where. And that is the purpose of my talk today. Again, this is a representation of the patient is lying here with the head end towards me. So it can rotate to the head end rotate away from me. So the image intensifier going to the right of the patient give you RAO view frontal, and if it goes to the left of the patient, there will be LAO view, and extreme will give you lateral. Right? You could theoretically do even more steep view, but we don't need to do that, because if you understand these are only a reverse of other views, so we don't need to discuss that. Now, this is another view of the patient to show you the cranial and caudal tilt. I will explain to you why we do the cranial and caudal tilt later. But when you do a cranial tilt, the source of X-ray moves towards the feet and the image intensifier moves towards the chin of the patient. And in caudal tilt, it moves the opposite way. Okay. Now, before we go on to interpretation of angiogram, please remember that the angiographic image is only a shadow, and shadow will depend on where the source of light is and what is its relationship to the object. Therefore, the shadow, you must have seen when you are standing in the sun, when the light is on one side, and depending on how close you are to the light, your shadow can be very small, it can be very long, it can be oblique, it can be moderately long, it can become very long, depending on the angle of the light to the body. Similarly, a shadow in the sun, you have seen it, no? When a pole and the shadow of the sun, it changes according to the position of the sun. So the most conventional view is, suppose you have a structure like this tube. If you take a cross section out of it, this view is called a cross section, also called an en-face view. So it will look like a circle. If you look at it from the side, it will look like a two parallel lines. I mean, you want in a sectional view, you won't see the third dimension. That's I have drawn here to show it is a tube. But what you will see is actually only two parallel lines. When you see two views, you put both together and know that it is a tube, isn't it? Otherwise, if you see this alone, you will think it is a circle. If you see this alone, you will think it is a rectangle. If you see both these together, you know that it is a hollow tube. Am I clear?
Yes, sir.
Yes, sir.
Yes.
Now, these two views are called orthogonal views. This is cutting straight across, and this is looking at it from the side. This is called orthogonal views. But if I don't take strictly perpendicular, I take at angles, no, like this. Then what will happen? This will not be a circle anymore. It will become an oblong. It will become oval. Right? Now that oblong is important for echocardiographic image, which I will talk to you in a separate lecture. But remember that in X-ray, by and large, we go to two perpendicular views, so that in our interpretation is correct. Now this orthogonal view is also important for the lesion. Suppose you have an atheroma occupying the lumen like this. In one view, it will look like this, that it is occupying indentation like this here. But in another view, if you look at it from here, you may think that the lumen is normal because the dye is extending from wall to wall. You get my point? If you look from here, you will see the indentation in the contrast like this because of the atheroma here. But you look from here, the dye is extending from wall to wall. The black is the dye, okay? From here to here. So from looking from here, the artery will look normal, but looking from here, the artery will look like 60% indentation. That is why you do multiple views in coronary arteries. Can you see here a lesion which is very marked in this view? In another oblique view, it's not so marked. So the same lesion in two different views may look different. Get my point? Remember, this is a RAO view, this is RAO view, and this is LAO view. So the same lesion in two views may look quite different. In one view very tight, in another view not so tight. So you need orthogonal views in mixing. Now, when you do orthogonal views, that's why you take multiple views and multiple this thing. And also, since you take multiple views, you must also know the cardiac anatomy when you do a coronary angio. For example, here. Now, again, I'll go back to, let me go to the heart again. Yeah. See, look at the left main coronary artery here. If you do a straight LAO angio here, you are looking along the length of the left main coronary artery and the proximal LAD. Can you see that? So the left main coronary artery and the proximal LAD will be foreshortened. Therefore, you may not be able to see the details of the proximal LAD very much here. On the other hand, if you do a left anterior oblique with cranial tilt, you will enlarge and elongate the proximal part of the left anterior descending artery. Yes? Okay. So when you do that, you get better views. But when you do cranial view, sorry, I didn't get it. You said something? Okay. So
No, sir.
what elongates the proximal part of the coronary artery will shorten the distal part of the coronary artery. It may do it differently. Therefore, you have to do again other view for the distal coronary artery. I keep repeating that again and again because that's the principle of angiography. Now, whenever you do an angiogram, you must know where the cardiac chambers are. And I have borrowed some of these figures from a YouTube video. I don't know, maybe some of you would have seen from Sri Chitra Trinal. One Dr. Rao has put up a YouTube video on, and I borrowed some of these figures from that. So he has shown beautifully, when you do a LAO cranial angiogram, you must know where the left ventricle is. You must know where the left atrium is. You must know where the right ventricle is. Because then you can identify the branches much easier. So the left anterior descending artery is in the interventricular groove. So anything to the left is left ventricle. But anything to the left means only up to the circumflex artery. Anything above the circumflex artery is left atrium. So it's beautifully marked here. Anything above the AV groove is left atrium, which is foreshortened here. You don't see the full LA. You see the most of the LV here. The septum is end on, so like the side of a cell phone, you won't see the septum much except the profile. All the branches here are on the surface of the LV, and they are the diagonal branches or the OM branches. The branches on this side from the left coronary artery would be the septal, the right ventricle. So that becomes simpler. Whenever you do a coronary angiogram, you must know where the cardiac chambers are. Now, when I discuss with PGs, I find there when I show them this angio and they tell me where is the LA in this case, I find many of them cannot identify where the LA is. If I ask you where the pulmonary artery will lie in this view, I doubt whether some of you can tell me that. So that you must know the cardiac anatomy even when you are doing a coronary angio. Okay, the degree of LAO you can judge by the degree of overlapping of the heart on the spine. For example, in frontal view, the heart overlap, but it has got that characteristic ovoid shape. This is the frontal view. As you go into LAO view, the heart becomes oval in shape. In mild LAO, it overlaps 50% here and 50% here. Okay. When you go to steep LAO, only a little bit is behind the spine. Only 1/3 is behind the spine. Most of the heart is in front of the spine. And when you go to lateral, the entire heart is in front of the spine. Now, why am I telling you this? Because I already told you how to identify oblique view with the chest X-ray, isn't it? Why am I telling you this? Because when you do an angiogram, you tend to reduce the field of interest. You don't get clavicles, ribs, everything in an angiogram. You get a much more limited view when you do an angiogram because that improves the quality of angio. Now look at this view. Do you see the clavicles? Do you see the two set of ribs? So how do you make out it's LAO or RAO? You make out LAO or RAO. Suppose you didn't have the coronary angio here. How do you make out? One, the heart is ovoid in shape. Two, the spine is always visible. Whatever be the degree of field cutting you do, the spine will always be visible. The spine is going towards the left of the heart. Therefore, this must be LAO view. Now, how much LAO view? Very little of the heart is behind the spine. Very little of the heart. And therefore, this must be quite a steep LAO view. So this is a steep LAO view. And why is it cranial? Because you're looking at it from above and the diaphragm is seen. Now, although those ribs and clavicle and everything are useful, when you're interpreting an angiogram, they are not visible. So you must learn to identify RAO and LAO based on the shape of the heart, on the position of the spine, on the amount of heart behind the spine, and whether diaphragm is visible or not. These are the clues to your identifying the projection. That's the foremost point in describing an angiogram. You must know what is a view. So, you know familiar how to identify LAO cranial in a limited field?
Yes, sir.
Okay. So this is a figure which tells you AP, shallow LAO, steep LAO, and lateral. How much of the heart? The same thing holds good for RAO view. When you go to RAO view, the AP, when you turn into this is the AP view. When you turn into RAO view, you will get the typical cardiac egg contour, but some of the heart will still be overlapping on the spine. Steep RAO view will be very little will be overlapping, and lateral RAO view or right lateral, the heart will be clear of the spine. The same principle on the RAO view also. Okay. Right.
Sir, one doubt, sir.
Sure.
Sir, about the diaphragm, sir, what you told, sir, relation like to the cranial and caudal, sir, I didn't get it.
See, when you look from above, see, normally you are looking like this at a horizontal plane. Okay, you don't see the diaphragm much. You don't see much of the diaphragm. But when you look from cranial, from here like this, the heart and diaphragm will overlap. So if you see a lot of diaphragm on the heart, you know it is a cranial angiogram. Can you see the diaphragm is almost half of the heart?
Yes, sir. Yes.
Therefore, it is cranial angulation.
Cranial. Okay, sir.
Now, RAO view. How to identify RAO view? Look, I told you, this is the typical, the egg-like contour of the heart. The spine is here. The spine has gone to the right of the heart. Therefore, it must be an RAO view. But it is still overlapping the spine. Therefore, it must not be a lateral view. So this must be a somewhere shallow RAO view. Can you see this is also an RAO view overlapping the spine? If it was steep RAO view, the heart would come and overlap very little on the spine, or it would clear the spine like this. So these are two examples of RAO views. I'm sorry, maybe this is AP and this is RAO. This is AP, this is RAO. No, wait, sorry. This is RAO straight, this is RAO cranial. This is because, can you see the diaphragm is thin? Yes?
Yes, sir.
Yes, sir.
Yes, sir. Yes, sir.
Yes. So this RAO straight and RAO cranial. Now, in this also you must be able to identify the chambers. Where is the LV here? Look for the LAD. Anything on the left side of LV, LAD is LV, shown in yellow here. Anything on the right side of LAD is RV, but only up to the AV groove. What is lying in the AV groove? Hello?
Circumflex.
Circumflex. Yes. So now you know where the LV is, you know where the RV is, and now you know behind the circumflex is LA, shown here. Okay. Right. Where will the RA be now? Tell me. Come on, wake up.
RA will be behind.
Behind? Behind whom? Behind what? I know you can't point out in this angio, but you can tell me, no? Describe it nicely.
Behind RV.
In this figure, tell me, Baba, how do I know behind? Behind, I see LA there. Come on, guys. I've been talking for 45 minutes. I thought you understood.
Posterior to LA, sir, because that right AV groove will be running on that side, so we won't be able to see in this on-fast view.
Not exactly. See, the RA will be lying plumb in front of LA here. It will be just, you cannot mark RA now because it will be lying on this. Here, exactly. You will see the atrial septum N phase. You will see the atrial septum, also called as the frontal view of the atrial septum or the on-phase view of the atrial septum. The RA and LA will be lying one behind the other. So if I have to draw RA, I will draw it exactly on top of LA. Are you following or not?
Yes, sir. Yeah.
Yes. Don't say
Yes.
behind. Don't say behind and above. This is the AV groove. So the RA has to be here. The only thing I cannot draw it separately. It will have to overlap the LA. Sorry. RA and LA will be overlapping here. RA will be in front. LA will be behind. Yes. Am I clear?
Yes.
Okay.
Yes, sir.
When you do a cranial tilt, you see more of diaphragm. You see again between the circumflex. You know, when you do a cranial tilt, the circumflex goes up, and the LED comes down. You're familiar with all these views. You know this probably better than me. But now the LV lies between the circumflex and the LED here, and RV lies here. But the problem is now the LA has shifted because the cranial tilt. LA is no longer, you don't see the AV groove here anymore. Where's the AV groove now? The AV groove is here because of the cranial tilt. Yes? Therefore, anything above the AV groove will be LA. Very little of the LA will be seen here. Yes?
Yes, sir.
Okay.
Yes.
Now, this is something difficult to understand unless you have a model. Think about it. Without cranial tilt, you see RLL all side by side. But when you have cranial tilt, suddenly the circumflex and LA disappears from sight, and the heart is actually foreshortened. You don't see the egg-shaped appearance anymore. Okay, you're all familiar with this view, isn't it? What is it?
LA
Spider view. Spider view. So this is one of the most important views for bifurcation. LC bifurcation. Okay, but that's not what I'm teaching you now. What I'm teaching you is where are the cardiac chambers here. So cardiac chambers, LAD is here. Therefore, on the left side is left ventricle. This is the circumflex. Therefore, between the LV, circumflex, and then comes, what is this, LA? Now, this is a very unusual position. You must remember in a caudal view, the LA goes down. And between the LV and RV is the left anterior-descending artery. So, it is all very confusing unless you have a clear mental image. When you do cranial tilt, it looks like this. When you do caudal tilt, LV goes on top, LA comes at the bottom. When you do cranial tilt, LV comes down and LA goes on top. Okay, are you able to relate to this figure?
Yes, sir.
Okay. So now, any branch going in this direction, what will be those branches? From here going this way, what will it be? I'm showing you from this, the branches going like this. What are those branches?
OM.
Very good. OM branches. If suppose some branches are going like this, what will they be?
Left atrial circumflex.
Yes, atrial branches. Very good. Suppose some branches are coming from like this. What are these?
Diagonals.
Diagonal. Very good. Will you see the septal in this view? Well, you may see a few septal, but really speaking, you won't see the septum here. So some foreshortened septals will be seen. So that's important. No? If you see a atrial branch coming like this, you shouldn't mistake it for a diagonal or some other branch. Sometimes you do get fistulas, you do get unusual structures filling from the coronary angio. So you must know exactly in all views where the LV is, where the LA is. Okay, what view is this? Come on, guys. You must be very, very sharp in these things.
Leocranial.
Sir, areocranial.
Areocranial.
Areocranial. And okay, so nice view for profiling the mid LAD. Also shows all the septals beautifully. The circumflex is out of view behind. Okay, so here the LV is all disappeared. Why it has disappeared? Because all you're seeing is the septum. It is the on-fast view of the septum. If you take out the LV RV wall, you will see the on-fast view of the septum. So what is overlying this part? What is overlying on top of this is the RV. You see only a little bit of LV in the above portion. So any branch going in this direction is diagonal. Any branch coming down perpendicularly is the septal. Right? What is this view? Oh, sorry. What is this
Lateral.
view? Lateral. Yeah. Lateral. Agreed. Lateral. I don't know whether cranial tilt has been given, but a little bit of diaphragm. That may be because the table is a little higher up position. But I don't think it's cranial. So in lateral, you see the LAD forms the anteriormost border, and what is in front of the LAD is a small bit of RV. Now, one of the radiological signs of RV enlargement is increase in the retrosternal space. You must have read. Normally, retrosternal space is limited. If the retrosternal space is increased, the RV, it's supposed to be one sign of RV enlargement. So this is the retrosternal space here. So the most of the view in this view, you see the LV and the circumflex is here and the LA is seen a little bit above there. So these figures are very useful to know the lie of the hearts. Okay, right coronary artery, equally complicated. The beginning part comes from the aorta, comes forward, and then it goes down and rightward, and it turns around the AV groove, goes all the way to the crux, then turns around and runs up to the apex, again forward and leftward. So it's a very complex course. You do many views, and I've shown only one view here. Yes, come on, what view is this? Come on, guys, quick.
Eleocranial.
Eleocranial. Steep elevo, mild elevo, you never told me. I've been talking so long and still you're not using the terms I want you to use. Spine is here. Can you see the spine?
Spine is leocranial.
Spine is same, heart is still overlapping the spine.
Steep elevo.
Yeah, steep elevo, but it's because
Steep
most of the heart is in front, and even the left posterolateral branch is in front of the spine. Therefore, it must be a very steep elevo, but it's still overlapping the heart and the spine. Therefore, it's not true lateral. Steep elevo and cranial diaphragm is seen. Okay, so now can you identify the chambers? This is what is called the four chamber view, isn't it? When you do a echocardiogram to show this view, you should call it a four chamber view because you can see all four chambers. This is the posterior descending artery, therefore it's the posterior interventricular groove. So it separates the RV from LV. RV, LV. Above the AV groove is the atrium. This is the RA and LA both together. There is no landmark to identify LA and RA. There's nothing to identify this. But anything above the AV groove is atrium, right ventricle, left ventricle. Yes? Is that clear?
Yes, sir. Yes.
Okay. And this is the acute marginal branch forming the anterior cardiac border in RAO view. Sorry, LAO view. Now these figures you have to memorize, not memorize, understand, sorry. Okay, this is the simplest view of when you do a RAO of the right coronary angio, the left heart chambers are all hidden behind the RA and LA. LA lies behind the RA here and LV lies behind the RV here. Therefore, RA and RV are separated by the AV groove. So you know where the RA ends and where the RV begins. So any branch going on this side is the RV branch. Any branch going on this side is the atrial
RV
branch.
branch.
Atrial branch. Okay. So now we come to the ventricular angiogram. What view is this angiogram?
Areocranial.
Elevocranial, sir.
Oh my God.
Sorry,
Areocranial, elevocranial, only AP lateral is left. And then caudal is left.
Areocranial, sir.
Steep
Areocranial.
Steep
Okay.
areocranial. Okay, whoever said elevocranial is wrong because the heart has still a typical egg-shaped appearance. The spine has gone to the right of the spine, right of the heart. Therefore, it is typically a RAO view. But is it steep RAO or mild RAO? It is steep RAO because very little of the heart is overlapping on the spine. If it was mild RAO, half of the heart would be overlapping on the spine. If it was total lateral, the heart would be clear of the spine. Now this is the RAO. Now I don't think there's any cranial. I think just because they have included more of vertical extent, you're seeing the diaphragm. Because when you do a true cranial view, the heart has to overlap the diaphragm. Okay. Now is the heart overlapping the diaphragm?
No, sir. No.
No, sir.
So don't call it cranial. You have to be careful. No? Just because diaphragm is seen, don't jump to conclusion it is cranial. You have to see whether the heart is overlapping the diaphragm or not. Somebody opens the field from head to foot, from here to here, you will see the diaphragm. You will not only say, you will even see the pelvic bones if you open enough. That doesn't make it cranial. The heart has to overlap the diaphragm. This is not cranial. This is the simple straight RAO view done most commonly for LV assessment, MR assessment and all that. Right? And it is steep RAO view. No. Steep means more than 40-50 degrees. That's not steep. It may be 50, 55, 60, 65, 70, doesn't matter. Okay. And what is the view? Anatomical figure corresponding to that is this one. Now, oh, sorry, one moment. Oh, what happened? Just a minute. I lost the image. Okay, can you see my image now?
Yes, sir.
Yeah, okay.
Yes,
So,
yes, sir.
now, see this, this is just a diagram to explain this angio. Although I have shown only the LV angio is opacified, you must know where the RV is lying. The RV is lying plumb on top of it like this. Like this. So, the septum is en face, it's facing you. That is why this view is not a good view to comment upon for VSD. Because the VSD is present, it will be coming towards you. How can you comment on a VSD which is coming towards you? Because the VSD jet will be hidden in the LV opacified mass. Therefore, this is not a good view for commenting upon VSD. Angiogram is best for whatever is profiled sideways. Now, for example, this view is best for commenting upon the LV shape, for LV contractility, for mitral valve, for mitral regurgitation into LA, for LA size, for LV outflow, for ascending aorta. Those are the structures which are best seen in this view. But it's not a good view for seeing the arch because here it is not profiled. It's not opened out yet. So here the RV is not opened out. The septum is not profiled. Therefore, you should not talk about VSDs in this view. Just to explain, look, this is how it looks. Although you are seeing the LV opacified, the red color, the RV blue color is actually sitting on top of it like this. Can you imagine that?
Yes, sir.
Yes,
Okay.
sir.
Now,
Yes, sir.
now you see, now another important point which I will refer to again later on in my slide. Now you see there's a coronary artery coming from here and going towards the left. Okay. I want you to tell me whether this coronary artery is in front of the pulmonary artery or behind the pulmonary artery.
Behind the pulmonary artery.
Okay.
Behind the pulmonary artery, sir.
Why do you say that?
Because the aorta is posterior And pulmonary artery is
Is
anterior.
anterior.
Why
Yes,
it can
and
come?
RV.
Yeah, that's not enough. No, it can come from aorta and then go anteriorly. It can come from aorta and then go anteriorly like this. Okay, just remember this. We'll come back to that figure little later. Okay, now these are what view is this? There are two views shown here. You can describe this. Both the views you describe this first and this first. This second. Come on. This is a still picture. This is a movie.
LAO plane, sir.
Oh, sorry. Okay, you are describing the first one.
Spine is
the
up.
Are you describing the first one or second one?
The
Second
move.
one, eleo-cranial.
Yeah, one person, please. When you talk together, I can't hear it. Yeah, this is the first one. Can somebody tell me what view is this?
Sir, that is LA.
Plane.
views.
Plain LAO view, sir.
Okay, very good. That's not entirely correct, but it is a good attempt.
Some
Okay.
yes,
See,
some diaphragm and
yeah. Can you
heart
see
is overlapping.
this heart is no longer egg-shaped. It's more oval in shape. Okay. Then you must also remember where is the spine. The spine is here, and you can see the arterial catheter coming from here. Therefore, this is posterior. Yes. So more than 50% of the heart is overlapping the spine. So what view is that? Shallow LAO. Okay. Now half the heart is overlapping the diaphragm, and therefore it is what?
Cranial,
Cranial.
somewhat cranial. Sir.
Cranial tilt. This is also elevocranial tilt. Oh, sorry. This is elevocranial tilt, but this is slightly different. What way it is different? This is even less LAO. Can you see the left ventricle is entirely behind the spine? Here, half of the LV is in front of the spine, half is behind. Here, the LV is entirely behind the spine. So this is a shallow LAO. This is more steep LAO. But the difference between this and this is this ventricle is still ovoid, whereas this ventricle is elongated. Why did we do this elongation? Because we want to separate out the basal portion of the ventricular septum from the mid portion from the apical portion. Because if you have a VSD here and here and here, we want to separate it out. You want to elongate the septum. Therefore, you are given more cranial tilt. And therefore, when you give more cranial tilt, the left ventricle becomes even more elongated. Can you see how elongated it becomes? So, this is an example of a shallow moderate LAO, mild cranial angulation. This is an example of shallow LAO with very steep cranial angulation. Why do you give steep angulation? Then you elongate the septum. Then you can separate the basal VSD from mid-muscular VSD from apical VSD. You can separate it. So if you have 2 or 3 VSDs, you will be able to see 3 distinct jets. But if you have 3 jets in this view, 1 or 2 of them may overlap each other. Okay. Also, the aorta goes horizontally like this. Can you see this? It's going like this. You know. So the LV outflow is foreshortened. When you look from the left side, it is shortened. So if you give cranial tilt, you can make it longer. And so you get a better view of the LV outflow tract. Therefore, you give more cranial tilt if you want to elongate the ventricle and elongate the septum. You also get better views of the left ventricular outflow tract. But when you give too much of cranial tilt, what happens? The arch and all will get distorted. So what is good for ventricle may not be good for arch. You must remember that. Okay. So you must plan your angio as to how many number of angios you can do and how to do it. Are you following what I'm saying?
Yes.
Yes, sir. Yes.
Okay. Right. Now let's come to the right ventricular angio. Now, when you do a right ventricular angio, what view is this? Come on. Now this is practice for you. You must. What view is that?
AP view, sir.
AP view, because
APV only, sir.
yes, because both the ribs are symmetrical. The vertebral, the spinous, what is this called? Pedicles of the vertebrae are exactly symmetrical, and the spine doesn't appear rotated. So it is a straight AP view. So when you do an RV angio in AP view, the tricuspid valve lies on the left border of the spine, as shown here. This is the corresponding diagram to explain that angio. Then RV inflow forms an apex here. Outside that is the LV, which you won't see, and then it leads into the outflow tract. Okay. Now, this is what the model looks like. RA, LA, and it looks like. Okay. Now, what is the problem in this view? The problem in this view is, although the RV and tricuspid valve are well shown, this portion is foreshortened. Can you see it's overlapping here? The RV is still here. This is the RV, and the RV outflow is overlapping here. It's overlapping here. Can you make out?
Yes, sir. Yes.
Yes. Why is it overlapping? Because from here to here it is horizontal. It is lying horizontally, like this. When it is horizontal, in frontal view it will overlap. Am I right?
Yes, sir.
Okay. So if you want to see RV outflow and pulmonary valve well, what view should you do? I told you, no, anything in doubt, do
We have to
perpendicular
give
view.
cranial tilt.
No, yeah, you can do cranial or you can do lateral view. One of them. Okay, one of the two, either cranial or lateral. So that's what we have done here. See, we have done lateral. Why it is lateral? Why it is lateral? Can you explain why it is lateral to me?
The ribs
RV
are
is anterior.
RV is anterior. Oh, that's not
Totally
it.
anterior
overlap on each other.
and
Yes. You see that the spine is clear of the heart. There's no overlap between heart and the spine. The sternum also, the two, the sternum has two sets of borders, the right border and the left border. When you are in oblique, they often separate out and you can see multiple borders. Here it is perfect, right? And you see only one set of ribs. So it's a perfect lateral, and there is diminished retrosternal space, indicating some right ventricular enlargement. So when you do an RV angiogram, you see the typical right ventricular triangular shape and trabeculation. Now that's the model to explain to you where the RV is. But once you do that, you see that the RV outflow angulates posteriorly like this. And let's see what it shows. Oh, sorry, in this view it's not so angulated, but in tetralogy and all it angulates posteriorly. This particular angio is not going anteriorly. Okay, anyway. So if it's angulation, a cranial tilt or a lateral view will show that like. Okay. Now in this view, you must know. Tell me, where is the RA here? Can you tell me where is the RA here?
Just in front of the
sir,
spine.
Your cursor.
in front,
Where is your
in,
cursor?
No, one person, please. One person. What did you say? Where is the RA lying here? I want to know where the position of RA is.
sir, in between the spine and RV.
Very good. Because the catheter has gone from IVC to RA. This is the RA here on the spine and in between the RV and spine, and has gone through the tricuspid valve into RV, and that is the tricuspid valve. Okay. By the way, what catheter is that?
Bergman.
Burman catheter, sir.
Burman, sir. Balloon is distal tip.
Sorry, that incomplete. You get only quarter mark. What catheter is that? Burman has designed many catheters. If you say Burman catheter, you get only quarter mark.
Reverse Berman catheter, sir.
Sorry, you lose that. You lose that quarter mark also.
No, not this. One catheter. Still balloon tips, sir.
Okay.
Okay.
Here the balloon is at the tip. Holes are proximal to the Burman. What do you fill the balloon with?
Carbon dioxide.
You use carbon dioxide in your hospital?
We don't have carbon.
Then why do you say carbon dioxide?
No,
Okay.
if not available, air.
Yes,
No.
ideal is carbon dioxide, but if not available, most of us use air. What is the disadvantage of air?
Rupture and embolism.
Okay, so one day I'm going to ask you air embolism in the heart. So suddenly I will ask you one day. So you will tell me the clinical features and treatment and all. I'm not discussing it today, but I've given you a warning that I'll ask you. Okay, now remember I asked you the lie of the coronary artery like that. This is a very important. Can you describe these two angios for me?
Yes, sir. The first one is the AP, sir. Plain AP. Sir, you are asking, sir, or complete?
Yeah, everything. Hey, come on, man. When I show an angio, I want view, I want description of the angio, I want diagnosis, everything.
Sir, the first one is the plain AP view, sir. You can see, and with aortogram, sir.
So the way to say it is iotogram done in such and such a view. Don't say plain AP view, it's an iotogram. Talk like a report, no? Iotogram done in such and such a view.
Yes, sir. And the second one, aortogram done in the lateral view, sir.
Okay, both of them are wrong.
Left, sir.
Somebody else can try. Hey, come on! I've just showed you. This is an egg-shaped heart. The apex is cut off here. Egg-shaped heart is overlapping the spine.
One is
This is a typical RAO view, and this is a typical LAO view. Steep LAO view. Heart is overlapping the spine. The spine is on the left side of the heart. So this is RAO view. This is LAO view. Iotogram. It's actually biplane of the same angiogram. Okay. Now what does it show?
it shows anomalous coronary.
Oh, come on. After angiogram, anomalous coronary. Then what is
Right-sided aortic arch.
Okay, no, I'm talking of, now let's talk of coronary. I've shown you this angiogram already here. I've discussed right aortic arch, aberrant subclavian artery, everything I've discussed already. What is a coronary? Describe the coronary for me.
The RCA is originating from the LAD, sir.
Okay.
This,
And coming, right coronary artery is coming from the, guys, come on, you're sleeping.
Yes, sir.
I showed you this angio only a week ago.
Yes, a single.
RCA arising from left.
I think you guys are sleeping. Either today or you were sleeping last week. Okay. So the right coronary artery arising from the left coronary artery and coming into the right AV groove. Now what I am interested is whether this is coming in front of the PA or is coming behind the PA. That is what I am interested in. You got two views here. Can you tell me? You see, I'll tell you. See, that is why I have behind. Yes, tell me. What is that?
Behind pulmonary arteries, sir.
No, you're wrong. See, the left coronary artery comes from the left sinus, goes behind the pulmonary artery and emerges on the left side. So it comes behind like that here. There it gives off the RCA, and the RCA is making a convex loop upwards like this and coming to the right side. Yeah, like this. It's coming. Now, can you see the corresponding specimen here? It's coming from the left and coronary artery like that. If it was coming from the left coronary artery behind the RV outflow, it will have to be concave like this, because this is a concave structure here and this is a convex structure here. Can you make out? Similarly in LAO, lateral or LAO, whatever. Can you see the RCA is making a big convex loop on front. Now in this view, where is the pulmonary artery? The pulmonary artery is lying in this convex like this here. You must, that's the importance of knowing the cardiac anatomy. So can you see this? The pulmonary artery is lying here like this. So you're not seeing the pulmonary artery here, but it's actually lying here like this, like this. So now I know this artery is going like this to the right AV groove. It's coming from the aorta and then it's going like this to the in front of the like this pulmonary artery. You understand? If it was going behind, it would form a concave loop. Like, because if pulmonary artery is lying like a circle here, like this, pulmonary artery is here. If it is in front, you will see it like this. If it is behind, you will see it like this. I think I had an angio in Frontier last week. Surya, do you remember that anomalous LCA?
Yes, sir.
That was going behind the RVOT.
Yes, sir.
That angio I must, I'll see if I have, I can show it to you later. Anyway, so can you see this? This is in front and this is, if it was behind, it would go like this. So you have to imagine that the pulmonary artery is lying in this concavity here, and that is the specimen here. This sort of angiogram is much easier to interpret if you have the specimen in your hand. So the left coronary artery emerges from the aorta here. So look, it comes out here and then it arches like this on top of the pulmonary artery and goes to the right AV groove. If it was going behind, it would form a concave loop like this. Now I'll go back to the angio I showed you right at the beginning. Remember I told you one angio, I'll come back. I don't know where that angio is gone. Wait. Yes, no, not this one. No, I don't know where that is. I think anyway, yeah, we'll do it some other time. So you got that? Did you understand or not?
Yes, sir.
So whenever you have anomalous coronary artery, please you have to identify where the pulmonary artery is and see whether it's in front or behind. So it can go in front of the pulmonary artery, it can go behind the pulmonary artery, it can go even behind the aorta. There are 3 or 4 different courses for anomalous coronary artery. Please read up everything about it. Okay. Now, if it is in front of the pulmonary artery, it's important for patients with tetralogy of Fallot. For example, this patient has the right aortic arch and all that, therefore must be tetralogy of Fallot. It's very important it's crossing in front. If it is behind the pulmonary artery and it is in between the pulmonary artery and aorta, it can cause compression. If it is behind the aorta, it is safe. Nothing can compress it there because behind the aorta is only LA. LA can't compress it. Okay. Now this angio also I showed you some time back. Can you tell me what view is that?
Laid back view.
Laid back view. What is laid back view? Explain to me. Explain to me.
PA caudal. Epic caudal.
No, this is not PA caudal. This caudal is right. PA is not correct. The ribs are all oblique, no? It's a LAO, no? The heart is it's a shallow LAO. Okay. Anyway, Now, this is the unfast wave. You can see one coronary artery coming from this sinus in front. So this is enfast view. You see the three sinuses and cuff beautifully, and the corresponding view. Can you see the caudal view here shown here? LAO view, caudal. I've turned the heart so that it reflects. I've removed the anterior wall. I've turned my model into LAO view, and I'm looking at it from the apex. This is the apex. I am standing at the apex and looking up at the aortic valve. So the septum is foreshortened, LV is foreshortened, but I am able to see the three sinuses and three cuffs beautifully, separately. I can identify which coronary artery is coming from which sinus, just like one is coming from here, one is coming from here. There is no coronary artery coming from this sinus. Yeah. Now, but this is okay. This caudal view and what is it? Laid back view is okay for knowing the sinus origin of coronary artery. But then it doesn't serve much purpose for telling me the distal coronary arteries, branches and all. It also doesn't help me in the arch. I don't see the arch at all. Why do I don't see the arch? Because in steep caudal view, the arch is completely hidden. It is foreshortened. Do you see the arch here? It goes like this and then comes like this. So you don't see the arch. It doesn't profile at all. So this view is only for knowing the sinus origin of the coronary arteries, and this is the corresponding anatomical view. Again, I am emphasizing how to understand this anatomy and make a diagnosis. This is the enfast view. Okay, is that clear?
Yes, sir.
Okay.
Yes, sir. Yes, sir.
Okay, it's already 3:30, so I think I should stop now. Right. So what I have done today is to show you the surface markings of the cardiac chambers, how to identify oblique views, AP view, lateral view, different degrees of oblique view, different degrees of cranial and caudal tilt, how the cardiac fillet changes in different shape, how the coronary arteries changes in different views, and how to select views according to the structure that you want to see. Now, you cannot understand and digest all of it in one session. I can understand that. You have to, first thing is, I think you have to get a model. I would suggest strongly get a model. It's available online, it's available in anatomy and bookshops everywhere. So, you can get a model, or even these medical companies, some of them give it. So try to make use of that whenever you describe an angiogram so that you understand that. Some models are very good, but some models are not very good. You have to find a good model which are really representative of the normal anatomy. Of course, you cannot have models of abnormal anatomy because they don't make it. But models of normal heart, if you have in your hand, that is good enough so that you can identify structure. But please try to interpret every angiogram in the light of, and try in each one you must be able to identify where each chamber is, each structure is. Suddenly one day somebody asks you where is the right coronary artery in this, you must be able to pinpoint. You shouldn't have to think. If I suddenly ask you where will be the left apex of the LV in this angiogram, you have to point out. This is very important for your interventional procedures, to know where exactly each spot in the heart is without any landmark, because most of the time when you do intervention you don't have a landmark. Okay, so I think I'll stop here.
Sir,
Yes,
any for shallow and steep, any particular cutoff is there, sir?
see, if you most angiogram nowadays give the printout. Most modern systems, when you do an angio, automatically it prints out on the top LAO 30, cranial 30, and all. It prints it out. So actually nowadays you describe it as 30 degrees LAO, 60 degrees LAO, and so on. But in an examination, you don't really have to bother about that, and these values are not fixed. In one person, 30 degrees RAO may give you a best image. In another patient, 30 degrees may not give you a best image. 40 degrees may give you a best image. So somewhere between 20 to 30 degrees is considered shallow. Somewhere between 30 to 60, 70 is considered moderate. 60, 70, 80 is considered steep, and 90 is considered lateral. Similarly, LAO 20 to 40 shallow, 40 to 60, 70 steep, 70 to 90 very steep or lateral.
Okay, sir.
Okay. Any other question?
Sir, in
Sir, Surya, sir.
steep,
Yeah.
sir, there will be more overlap as compared to shallow or less overlap?
No, I can't hear you.
Sir, in steep view, there will be more overlap as compared to shallow view or less overlap?
Sorry, say that again.
In steep view, sir, there will be more overlap or less overlap as compared to shallow
See,
view?
the normal heart always overlaps and shallow always overlap. Moderate always overlaps. It is a steep and lateral we don't overlap. Steep overlap very little and lateral doesn't overlap. So the shallow ones and AP always overlap. So if you are considering by overlap, you must say half of the heart is overlapping, it is shallow. Only 1/3 of the heart is overlapping, steep. No overlapping, lateral.
Okay.
Sir, four-chamber view, is it shallow LAO or steep LAO, sir?
Shallow. Four-chamber view is typically 30 degrees LAO and 30 degrees cranial. Okay. Shallow LAO, cranial.
Sir, regarding
some people also call it hepatoclavicular view, 20 to 25 degrees LAO and 35 degrees cranial, hepatoclavicular view. Nowadays, people don't describe it as hepatoclavicular, fourth chamber and all. They actually describe what degrees they did. So, like you describe what you did, 20 degrees cranial with 30 degrees LAO. That is the best way of describing.
Sir, it is described LAO 40-40, sir. Around
40-40, yeah, I think there will be minor variations there. Hepatoclavicular, all those things, minor variation will be.
Okay.
Yes. Any other question?
Sir, regarding that abnormal course of the artery, sir, the one which you showed was like RCA arising from LAD. It had the convex.
No. It was LA, the one I showed. Yes.
Yes, sir. And what we saw was like LAD arising from RCA, sir. Does the concave and convexity thing applies to that also, sir?
Yeah, it applies to that. Anything crossing the RVOT front or behind, it remains the same. In fact, I don't have that angio. I will show it to you next time. It is on my phone. I will show it to you next time.
Okay, sir.
It applies to that also. Anything crossing RVOT, so you have to check whether it's concave or convex, convex upwards or concave downwards, convex downwards, downwards.
Yes, sir.
So hepatoclavicular view is same as apical four-chamber view, which is LAO shallow.
No. Apical four-chamber is used in echo. It's not used in angio. Yes.
Yes,
it corresponds to that.
Corresponds to.
Correct.
Shallow LAO cranial.
Yes.
Okay.
Sir, one more thing, sir, like indications of views in ASD, VSD, PDA and all those views, sir. Can we have, sir, like
indication
like
of what?
Like for MR, the good view, like you showed, sir, it is a RAO view, sir, where you can assess the MR, where you can see the LA, LV out and LVOT. So like that, different views where all we are using, sir. That can we have, sir, a short?
Sure, we can, but I mean, I thought the congenital fellows would be more interested in that. I don't mind doing that, but there must be other pediatric fellows also in your group.
Yes, sir. I think 15 people.
Yeah, good. So then we could do the angiographic views for congenital heart disease. You're talking, no? That's what you want.
Yes, sir.
Angiographic views for congenital heart disease. At least the common one, tetralogy, VSD, ASD.
Correct, sir. Correct.
Yeah, we can do that. We can do it one day, but again, I'll have to prepare it. I don't have it offhand.
Yes, sir.
Sir, can you simplify dot and I classification, sir?
Dot and I. Yes, I can, but I need slides. I don't have it ready now. Some other time I'll note it down, and some other time I will sort out your question. I know dot and I is also useful in anomalous coronary artery.
Coronaries, yes.
Yes. Okay, I'll explain to you some other time because I need slides, and it'll take a long time for me to find those slides and put it here. So one is dot and I, and one is angiographic views for congenital heart disease. Anything else?
Sir, will the coronary lay vary with the arch-sidedness, sir, on angio?
No, it doesn't. It won't vary with arch-sidedness. No, but it will vary if it is normal lie of the ventricle or inverted ventricles. Like in a CTGA, the coronary arteries will be inverted.
Because there will be a great arterial inversion also in CTG.
It doesn't depend on the great artery. It depends more on the ventricle. The LV on the left side, so left coronary artery will go on the left side. Sorry, on the right side. LV will go on the right side.
Okay.
So the morphological left coronary artery will go on the right side. But the aortic arch itself, it doesn't change.
Okay. Sir, will the left coronary originate from left coronary cusp and then will it run along LV or?
No. It'll
even there will be.
In fact, I showed you that laid back angio I showed you, no? That's like a CTG actually. I'll show you 1 second. Let me get it back here. Can you see the angio now?
Yes, sir. Yes, sir.
Okay. Now, normally the coronary arteries come from the which sinuses? I explained to you this when I talked last week. I thought I had explained all this to you. Okay, so that shows the coronary artery. Normally, the aorta lies behind the PA, isn't it? So, which are the which are the sinuses which give the coronary arteries?
Left and right, sir.
I noticed left and right. What is the position? Left anterior and right anterior. Okay. What lies posteriorly is what? The non-coronary sinus. You agree?
Yes, sir.
Yes, sir.
Okay.
Yes.
Now, in CTJ, what is the position of the aorta?
It is anterior and left to pulmonary artery.
Anterior. So, aorta comes anterior and the pulmonary artery goes posterior. Now, it's a anatomical principle that coronary arteries will always come from the facing sinuses. That means the two sinuses adjacent to the pulmonary arteries will give off the coronary arteries. The sinus which is away from the pulmonary artery normally will not give any coronary artery. Okay? Is that clear?
Yes, sir.
Okay.
Yes, sir.
So, in a CTGA, now we have three sinuses, 1, 2 and 3. This is what sinus is this?
Anterior sinus.
Anterior non-coronary sinus.
Non-facing.
Non-facing non-coronary sinus. That means in a normal aortic arch, the non-coronary sinus is posterior. In an anteriorly placed aorta, the non-coronary sinus is anterior. That is the first and foremost thing. So both the coronary arteries come from the two posterior. Now there are two posterior sinuses. Okay, one is the left and one is the right. Now, because the ventricles are inverted, the LV is lying here and the RV is lying on the left side, they will be morphologically inverted. That means the right morphological coronary artery will come from the left posterior sinus and supply the morphological RV. Am I making sense or is it confusing? The left posterior sinus will give the right morphological artery and it will supply the morphological systemic right ventricle. I'm going very slowly to make you understand. the left coronary artery will come from the right posterior sinus. It will be morphologically left coronary artery. There will be a circumflex and a LAD, and it will supply the morphological LV. Did I make sense?
Yes, sir.
Okay. So it doesn't arise from
like
the left
position.
It doesn't arise from the left sinus and go like that. It doesn't. It arises from the corresponding sinus. The right posterior sinus now acts as a left sinus actually. It's placed on the right side, but it gives out the morphological LC. And you know it's left coronary artery because the way it divides, no? It bifurcates into circumflex and LAD. Whereas this doesn't bifurcate. In fact, if you carefully see, you can see running in the AV groove here. You got it? Now you understood what is a CTGA coronary lie pattern?
Yes,
sir.
Yes, sir.
Okay. So when you want to do a coronary angio in a CTGA patient, it's better to take a multi-purpose catheter, so that whether it's the left sinus or right sinus or anterior sinus, a multi-catheter would be much more easier. And the preformed Judkins may sometimes give you difficulty because it may not be the ideal one for entering a posterior sinus artery. But sometimes even the Judkins just sits in, that's not a problem. You have to hunt for the posterior sinus if you can't hook it easily. That's it.
So right will hook the left and left will hook the right. Is it so, sir?
Yeah, true. Now this is only for a straightforward CTG. If you have dextrocardia and all that, then it becomes more complicated. I'm not talking about it. The straightforward CTGA, if you hook it like a left, you probably will get a morphological RCA. And if you hook it like the left right, you may get LCA, but you may have to hunt for it because RCA is not coming from the anterior sinus. Normal RCA comes from anterior sinus, no? Here it's coming from the posterior sinus. So sometimes anomalous RCA you have to hunt for it, no? Little bit with a little bit of change of catheters, maybe TIG catheter, or maybe with a ampular catheter, or even with a multi-purpose catheter. You have to hunt for it a little bit. Not difficult, it's easy.
Yes, sir.
Okay, any other question? No, we are done? Okay.
Yeah, yes, sir.
Okay, next time we are going to, I want to discuss something about angiography, a little more about angiography, maybe how to do an angio, contrast to injection and all those things. So, so we'll discuss probably on Tuesday. A little more about angiographic contrast and other things. Huh? How much to inject,
Okay,
what not, and all those things. Right. So no more questions. Okay. What is the attendance today?
So I think around 80 people joined.
Okay. Right. Good.
No,
Okay. Right. Thank you, everybody. Thank you.
Thanks.
Thank you, sir.
Thank you, sir. Thank you very much, sir.
Thank you so much.
Okay.
Thank you, sir.
Thank you, sir.